All right. Sorry, we were running a little bit late, but we are back home. We are live. This is Kriyas and American Surgery Center. My name is Kemal Erkan. Today, actually, we are here for a different reason. Today is we are here to. My family doesn't watch my live shows. What's going on with this one, Dr. Vaid? So I'm sure your family is watching them, right? My sister is calling right at the time that stuff starts, Um, okay, sorry about that. We were running a little bit late, and this is what happens when you have a full-time schedule today, and you were nice enough to actually be part of this event and talk to us about the colorectal cancer awareness.
Absolutely.
Now, before we start, Dr. Vaid, you have been with Kriyas and American Surgery Center since 2015. So if you can just give us a brief background about yourself and what you do with Kriyas and American Surgery Center.
So I'm Sachin Vaid. I'm a colorectal surgeon. I did my medical school from India and then part of my surgical training. After that, I was in London for 3 years, where I was a member of Royal College of Surgeons and actually furthered my surgical training over there. Following that, I moved to the States and I did my surgical residency and a colorectal fellowship here. And since 2015, I have been associated with Kriyas, and I am a colorectal surgeon with the group. So I work at a lot of places in different centers, in different capacities. So we have an office at least once or twice a week where we see patients. We have our surgery center, American Surgery Center, where we do the bulk of our colonoscopies and minor procedures. And we then also go to the hospitals like Christiana and St. Francis, where we do the big cancer operations and colectomies. I also go to Helen Graham Center, where I see the rectal cancer patients once every week or once every other week, depending on the census over there.
So in the hospital, you do actually do some of the robotic cases there, right?
I do. The bulk of my practice in the hospital, I would say 95% of it is minimally invasive. It's a combination of using the robot or the laparoscope. Less than 5% of the times, I do utilize the standard open technique, and it's all patient-tailored and patient-dependent, meaning if they've had prior surgeries, a lot of surgeries, and there is no planes, then we kind of tailor that accordingly. But more than 95% of the planned elective operations are done with the help of the robot and the laparoscope.
So, Dr. Vaid, we did 2 sessions with you last year. Colorectal Cancer Awareness Month. I'm not a big fan of these awareness months or awareness days. When the issue is extremely serious, then it cannot be just limited for 1 month or 1 day. Because of that, I don't do the Valentine's Day either. So you have to love people every day, right? So it can be just for 1 day. The cancer is not just for March, it's just all around the year. So this is a pretty, this cancer type has a big impact in our lives. Just many of the other chronic illnesses or other type of illnesses, it does, it can, if we are able to detect earlier, chances of survival is extremely high. And yet we still have a lot of struggles. The colonoscopy, for example, screening of colonoscopy, it's one of those quality incentives for many of the PCP offices and other practices. So if you can tell us what it is, where colorectal cancer is in terms of what it does to the society, to the population, how serious this issue is, and then we'll go into a little bit deeper.
Absolutely. No, colorectal cancer is a very impactful cancer in the United States. I would have to say that it's probably the third most leading cancer in terms of the cancer-related deaths, if you look at all the cancer-related deaths. And in the past, we used to say that, it's a disease or a condition of someone who's older, who's in their 60s. Hence, the colonoscopy used to start at the age of 50. But over the last few years, we are seeing more and more younger people actually having colon and rectal cancer. And from the Cancer Society, from the recommendation for colonoscopy has now come down to 45 years, which is good. But we are still seeing younger and younger people. So one thing I would say is that if you have any symptoms with in terms of your like any change in bowel habits, any new abdominal pains, rectal bleeding, anything which does not feel right, I think you should be seen by a colorectal surgeon or a gastroenterologist, and then he or she can evaluate you and figure out if a colonoscopy is needed. Colonoscopy is absolutely important because it can lead to diagnosis of a small precancerous polyp, which has not turned into a cancer. That's one, or cancer at an early stage. So colonoscopy can actually prevent you from getting colon cancer if we do it at regular intervals, because we would kill the polyps which turn into these nasty cells which become cancer. So hence, that's why colonoscopy is absolutely important. Normally, we say we start at the age of 45, and then we repeat every 5 to 10 years, depending on what the findings are. And of course, if you have a family history, we start even before that. So don't ignore your symptoms, get screened, because this is a preventable cancer. And if you catch it early, you are cured by a surgical procedure. I would say all stage 1 and almost, I would not say all stage 2, but most of the stage 2, you don't need any chemotherapy. Surgery is curative. And when we talk about a 5-year survival, we're talking about a 5-year survival of more than 80 to 90%. So that's a good number. But once we get advanced, then that's when the survival goes down and all those things happen. So we don't want to catch it late.
So what do you think people, where's the problem? Like, what's the problem that people don't want to actually get screened? Like, if I know, I mean, I don't want to actually make this about me. Recently, as you know, I lost my puppy, and trying to keep him alive for a long time. That's what we wanted to do. Like, and he was 13 and a half. If I was able to have another 6 months or another 12 months, and if it was just about doing some screening that was needed 5 years ago, I would have done that. In fact, we do better with those than for ourselves. Why are we not doing it? There must be, and then I'm going to tell you something personal, this time directly from me. So, and because there's some issues, I guess, there. So why are we not doing it? Why are we not taking it seriously?
Absolutely. First of all, Kemal, I'm so sorry for your loss. You know, I know that ever since I've known you, that, I mean, Buddy's been your best friend. So I'm so sorry for your loss, and I hope that you're doing all right. Now, I think most of the people are very serious about all these testings. I don't think that population at large or people at large are not serious about it. One is, I think, lack of awareness and education, meaning if they have any change in their bowel habits or they're having any symptoms, they sometimes don't know where to go. And they probably feel, oh, it's just hemorrhoids or it's something what I ate and things like that. But once it gets persistent, they then go to a doctor and they are examined. But that is not preventive now, because now they already have symptoms. So that is not a screening colonoscopy. So the screening colonoscopy is starting at the age of 45, which a lot of people don't know, because this is a new change which has happened. If you have a family history, it needs to be done even before that. So I think lack of education and awareness is one thing. And second is, people fear that, you know what, we'll have to do that dreadful prep, which is going to dehydrate us, and we'll have to come to the center. I feel good. Why am I going to let my body go through all of that? So that is a concern which people have. But I got to tell you, these days, the preps we use are very different from the preps we used even back in 2010s or early 2010s. These preps are low volume preps. They are not as dehydrating as the old preps used to be. And you don't even have to take all of them together. We've kind of learned that system, and we are getting better and better at that, so that we can improve the compliance with the patients. So I think more and more people are now knowing that the preps are getting better and they're getting screened. And I got to tell you, the advantage of getting screened and removing a precancer polyp or early stage far, far, far outweighs that bad day of preparation you had to go through for. It's actually less than half a day. It's not even 24 hours. Yeah.
So now, one of the last time I went, remember you were actually kind of not making fun of me, but you were saying that now it's the 45 instead of 50, and I'm in between. I'm 48 this year. And then last time I got my annual physical, my primary care physician said, okay, you have to do Cologuard.
Yeah.
Have you received one at home?
So Cologuard.
It's just so
I'll just tell you that. Yeah.
So it's a pretty traumatizing experience from the patient standpoint when you are not a patient, when you don't have anyone, and then you have this box. I didn't do it.
I think that's the right thing. Cologuard is not a replacement for colonoscopy.
I'm sorry, Dr. Valencia, if he's watching. So I didn't do it, so I returned it. So
yeah, Cologuard is not a replacement for colonoscopy. Absolutely not. It is not like we are saying we're going to skip a colonoscopy and we're going to do Cologuard. Why is that? It has high false positive and false negative. Meaning, if the test is positive, it has to be followed by a colonoscopy to see if there is something there or not. And it may turn out there is nothing. And if the test is negative, you cannot trust that test. So if a test has a high false positive and a negative, you cannot trust that. Number two, even in the Cologuard commercials, they say they detect cancers and advanced polyps. It's already late in the game when we are detecting those things. I want to detect early polyps. I want to detect small polyps, which turn into cancer. So that's what I want to detect, and that's what I want to remove endoscopically. If I'm going to wait for 15, 20 years or whatever, now I have a Cologuard positive mass or a cancer, I actually am late. I should have actually gotten that small polyp 10 years ago and removed it endoscopically so that no surgery, chemo, or radiation would have been needed. So to me, Cologuard is not a test which is a replacement for screening. It may be used in two situations, in my opinion. One, if someone is clinically sick, meaning they have cardiac issues, lung issues, and things like that, and they cannot undergo a regular screening colonoscopy, yes, we can start off with a Cologuard, but with the understanding that if it is positive, we got to do colonoscopy. And number two, it can be used in between screening, meaning if your doctor says, hey, you know what, come back in 5 years or come back in 10 years, and you are like, hey, I'm not comfortable with that 5-year program or 10-year program, then maybe every 2-3 years, you can get yourself Cologuard tested.
It's like when you explain this way, it's almost like the home test for COVID. Like, like half of them are false. Right?
Exactly.
So the PCR versus the home kit. So no, that like the other thing is that it was a lot. So getting the colonoscopy is one thing, and I do want to talk about this so then patients may not really feel comfortable, and they may feel like this is okay or it's not okay. But I think they need to know, and our patients are listening, my employees are listening, my friends are listening. When I had that box, the box actually stayed in the study room for at least 2 weeks.
Good.
And I'm like, so we were just kind of like looking at each other. I'm like, I don't think we're gonna do this. So then I'm like, what? Let me just, because I'm in medicine, so let me see what it looks like. And it got even more complicated. I'm like, okay, so I don't think this is for me. So that this was just a preventive. There wasn't any indication. So then I said, well, if I need something, I'm going to get a colonoscopy. Now, one question I have, in terms of who treats colorectal cancer, so there are different people, different specialties. There's a GI, there is a surgical oncologist, there's a colorectal surgeon, which would be you, radiation oncologists, and medical oncologists. What are the difference between those, and how does that decision being made, and who makes that decision?
So colon cancer is primarily a surgical disease. So the surgeon is the driver or the captain of the ship for management of colon cancer. So when you say a surgical oncologist, basically he is the surgeon who does cancer surgery. So in this case, the colorectal surgeon, which is me, am the surgical oncologist for that particular condition. So I am the surgical oncologist for colon cancer, the surgeon per se. Gastroenterologist's role is to help us diagnose that condition, meaning they do the colonoscopies, they identify it, they remove the polyps, and then they send it to the pathology, and that comes back as cancer. And then we say, okay, it is cancer, and now we got to treat it. So surgeon is one you need. If your cancer is advanced, or for surveillance, meaning follow-up in terms of CAT scan and blood work, you need a medical oncologist who's the chemotherapy doctor.
Mm-hmm.
And number 3 comes radiation in very rare circumstances. Radiation is typically used for cancer of the rectum or anal canal. For regular colon cancers, typically I would say radiation is not needed. So for colon cancers, basically you'll have the surgeon and you'll have a medical oncologist. Very rarely a radiation doctor, radiation oncologist. For rectum, we need all 3.
I see. So in some cases, you have to work with them together versus...
Yes. So I run a clinic at Helen Graham Center where we see rectal cancer patients from all over the state. And in that clinic, we have me as a surgeon, a medical oncologist, and a radiation oncologist. So we see, all 3 of us see a patient together, and we come up with a plan as to what should be done, what should be the sequencing. Sometimes they need surgery first. After that, they need chemo or radiation. Sometimes they don't need radiation or chemo at all, just surgery. Sometimes it's the other way around. We have to give them chemo for 4 months, then radiation, then do their surgery. So we decide all that sequencing and all that based on what the results are.
I see. Now, in terms of your communication with the primary care physicians and your recommendations for them, I know in our accountable care organization, we have a care coordination team, and we work very closely with our primary care and our specialists. Is there anything that you would recommend for them to follow, that if the patient doesn't want to do it, how to approach them?
So one thing is, please be aware, I'm sure you guys know that, and I know you guys are like very up to date with every changes. But please be aware that the new age of screening colonoscopy now is 45 years old for all comers. It used to be for African Americans and different for Caucasians, but now it's standard 45 years. Number 1. Number 2, if anyone has a family history of colon or rectal cancer, we need to start 10 years before. Number 3, if someone comes to you with any symptoms of pain, altered bowel habits, or bleeding, please do not ignore that. Please, because everyone has some sort of hemorrhoids. We can attribute all of the bleeding to hemorrhoids, but that needs to be examined. Because of late, I've had a few patients that they had bleeding for the past 2 years. Finally, they came to me and they had advanced cancer. Now, we could have stopped that from becoming advanced 2 years ago. So please do not ignore those symptoms. And if any questions or concerns, you have my email, you have my phone number, you have my text message. Call me, text me, email me if there's any questions or concerns about the management.
Dr. Vaid, thank you so much. I know you are in the middle of your office hours, and trying to do these events are extremely helpful. I do believe that our patients are benefiting from these. We benefit from these. Every time I do these, I believe there's new stuff that we are learning. And thank you for being part of this. So I'm sure we'll see you again for our other events. And until then, please stay safe. Thank you.
Of course. Happy to help.
Bye-bye.